Great. Hi, everyone, and welcome to this is Public Health Ambassador Takeover. My name is Jen Roux. My pronouns are she, her, and I'm a second-year MPH student at the Colorado School of Public Health. Today, we're joined by Dr. Cerise Hunt, Assistant Dean for Diversity, Equity, and Inclusion, and Clinical Assistant Professor at the school, to talk about Black women's health and infant mortality rates. Dr. Hunt, thank you so much for being here with us today.
Well, good morning, and I'm so glad to be here. Thank you for the invitation. This is really cool.
Awesome. Could you start out by giving us a little bit of an overview of your role at the school and what your public health background is?
Okay, well, just as you, I have a few roles that you mentioned. I am the Associate Dean for Diversity, Equity, and Inclusion. I'm also the director for our Center for Public Health Practice. And, and our whole goal within the center is excellence in health and excellence in practice. So it's a whole workforce development training center that bridge between theory and practice for the school. And I'm also, as you mentioned, an assistant professor in the Department of Community Behavioral Health here at Colorado School of Public Health. And so, it's interesting when I think about my public health background, it's always been rooted in racial and ethnic inequities. I started my career in 2006 at Colorado Department of Public Health and Environment in the Office of Health Disparities. And during that time, we had just released our first racial and ethnic disparities report, the 2005 report. And so I was charged with going throughout the whole state, educating local health agencies, community partners, residents, all about racial and ethnic disparities. And then at that time, because we were talking about the disparities, creating disparities plan. At that time, we were talking about eliminating health disparities. Now we're still trying to talk about eliminates, but now we're promoting equity and we're moving towards justice. So that was where I started. But, and as I was thinking about my public health career, one of my most rewarding public health accomplishments thus far, because I know that I still got a lot to do, I still got a lot of ways to go, was being part of the team that founded the Colorado Black Health Collaborative. And the Colorado Black Health Collaborative was established in August 2008 and is a nonprofit organization. And our whole mission is to achieve health equity in Colorado's Black community. So that is, I'm a still active member of Colorado Black Health Collaborative because we still haven't arrived to that equity within the Black community. But just as I'm framing this discussion, I think that's important to share with you.
Yeah, thank you for sharing that. And I find it fascinating how you say you have so much more that you want to do and that you're going to do while you have an amazing background. And I'm really looking forward to how you play into, your equity experience with this conversation, because I think it's really important to bring in. So with that, while we kind of walk into the maternal infant mortality conversation, could you describe for us, what is that? What is infant mortality and maternal mortality?
Okay, so when we, so maternal mortality, it refers to deaths due to complication from pregnancy or childbirth. So in its most simplistic nature. And then infant mortality refers to the death of children under the age of 1 year.
Okay, yeah. And so bridging that in a little, what are the racial disparities, particularly for Black women and children? What's the issue at play here?
Yeah, so I am going to frame my discussion. It is going to be primary, so I'm glad you stated that.
Yeah.
So the issues with Black women and children. So I was looking up the data, and according to the CDC, and this is from 2019, their infant mortality statistics, and they were looking from the 2017 period linked to birth infant death data sets. African-American Black women have about 2.3 times the infant mortality rate as non-Hispanic whites. African-American Blacks infants are 3.8 times as likely to die from complications related to low birth weight as compared to non-white Hispanic, non-Hispanic white infants. And then African-American Blacks had over twice the sudden infant death syndrome mortality rate as non-Hispanic whites in 2017. And when we think about this, in 2017, African-American Blacks mothers were 2.3 times more likely than non-Hispanic white mothers to receive late or no prenatal care. So I think that that's significance.
Mm-hmm.
In knowing that our whole role in public health and reproductive health and that prevention. But one thing that I want to end with is infant mortality rates for Black women with a college degree are higher than those for white women with just a high school education. So when we're looking at these infant mortality rates and mortality rates of Black women, income, we're not seeing much difference based on one's income or college attainment in those different areas.
Yeah, yeah, and you touched on a lot of different data and facts and kind of factors leading into those rates. But I mean, this isn't a new discussion. This isn't a new issue. So could you touch on, what factors do we need to consider when working to understand why they're so much higher for Black women and children?
When we think about this, that's a very good question. And thank you, Jen. And an important consideration for the health of Black women, and when I say we, the public health community, it's not just, so as we're thinking of, we all have a role in the advancement of equity. And when I say the we, it's the collective we in public health must be aware of both societal and health system factors that contribute to high rates of poor health outcomes and maternal mortality for Black women, who are more likely to experience barriers to attaining quality of care and often face racial discrimination throughout their lives. So these systemic barriers, and we make up the system, the systems that we work in, the different areas, but these systemic barriers such as racism, sexism, and other barriers have inequities. And so it's the historic injustices based on racial discrimination still influence us today because they're actually built into many of our institutions. And we see, like, even the American Public Health Association, the Colorado School of Public Health, we all have these missions to dismantle structural racism because folks are recognizing, well, wait a minute, these inequities are built in our policies, practice, and procedures. And as we're dismantling, we got to intentionally rebuild with an equity lens and an equity frame, because if not, we'll be building the same way. Mm-hmm. So it's just very important as we think about the health and the systemic issues and how it impacts one's health.
Yeah, thank you for sharing that and touching on so many points. I really love how you talk about the collective and the we. And so within that, how does this conversation need to be framed and approached with that equity lens, with dismantling structural racism, and how to promote equity-driven intervention?
Well, first of all, we need to be able to call out racism. Right. And so I'm going to go back to go forward. If you're willing to roll with me, Jen, can you? But, I have to go back to Dr. Kamara Jones, Morehouse School of Medicine, former APHA president. Racism is a systemic issue. Mm-hmm. And racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. And so these systems unfairly disadvantage some individuals and communities and unfairly advantages other individuals and communities. So that's how this system operates. And we have to understand that racism, so when we think about Black women and their health, and we're looking at racism, how does that impact one's health? It's the physiological aspects of racism. There has been increasing acceptance in medicine and public health of a concept called weathering, founded by Dr. Arlene Geronimus, University of Michigan School of Public Health. So School of Public Health, public health is rocking it with the research, which holds that the stress and living as a member of a community of color in itself takes a toll on the body. So the experience of racism and discrimination, prolonged exposures in the indignities and dangers of discrimination, it weakens one's cardiovascular system and immune system. And all of this leads to accelerated deterioration of the body. And so when we think about Black women's health and that whole notion of before one gets pregnant, that preconception health, well, we also know that what impacts is racism, that experience, so weathering. And we also know that access to care is not only the barrier, because we'll hear about access, and access is an issue to care for Black women, especially culturally responsive access to care, and being able to address the cultural needs. And I'll talk about that in a minute. But studies have also found that implicit bias on the part of the health providers often results for poorer treatment of Black patients. So, and so we as individuals within our public health, local public health agencies, state public health agencies, academic institution healthcare, we really need to check our bias and really ensure that all staff members, all providers, everyone from frontline all the way to leadership, not because, we're quick to make frontline staff do implicit bias, but we really need to have that implicit bias education and make sure that that's not perpetuating inequities. And then we hear about these myths that lead to inadequate treatment, such as one that Black people don't feel pain. There is a study on racial bias and pain assessment and treatment recommendations and false beliefs about biological difference between Blacks and whites. And this was led by Dr. Kelly Hoffman. So women, researchers, I'm kind of going with your women's theme, right?
I love it.
With the University of Virginia has studied this. And specifically, this work reveals that a substantial number of white lay people and medical students and residents hold false beliefs about biological differences between Blacks and whites, and demonstrates that these beliefs predict racial bias in pain perception and treatment recommendation accuracy. So it also provides the first evidence that racial bias in pain perception is associated with racial bias in pain treatment recommendations. And so all of this that we're saying are these factors that are real. There's this mistrust in our health systems. And I know we talk about the historic aspects of mistrust around Tuskegee experiment, but we're still hearing the stories currently of Black women when they go seek care, doctors refusing to listen to Black women, their symptoms are discounted. So there's this assumption, once again, bias, assumptions, stereotypes, that Black women don't know their bodies and that they're not educated. So if we don't change, and those are examples of those systemic issues that create mistrust, people are concerned about receiving care, especially if they cannot find a physician that looks like them. And if you're in a state like Colorado, we only have a handful of Black women doctors, a handful, I literally say handful, for the over 250,000 Blacks that live in Colorado.
Yeah.
So, and then another barrier, and I know I'm probably going on, but then there's economic inequities. Black women are typically paid just 63 cents for every dollar paid to white non-Hispanic men. And median wages for Black women in the United States are $36,000 a year, per year, which is 21,000 less than the median wages for white. So we have all of these factors impact one's health, and that we have to be aware of these different areas.
Yeah. Wow, Dr. Hunt, you paint such a picture between, the individual level all the way up to the institution of the different factors at play, and it just kind of lends to how complex the system is, and how, and when approaching it, we do need to kind of take a pause, look at ourselves as who's in the systems, who like us in public health practicing this, checking our biases, as you say, before, really approaching institutional and structural racism. So with that note, I know this is a complicated question in and itself, but, when we look to promote equity and the work that you've done within Colorado, what does that look like when there's so many different things at play?
You know, so one of the things is we need to take a multisystemic approach to promoting equity. And so that was like the point of the Colorado Black Health Collaborative. Not one entity can do all this work. When we talk about economic, we need the Department of Labor at the table. When we talk about educational attainment and opportunity gaps, because we know when you throw in race within educational attainment, you'll see the differences, the inequities that are occurring. So we need educators at the table. We need public health. We need healthcare systems, all working at a policy level to change policies and practice. But then I appreciate, Jen, because you said it too. But as I spoke, though, we also need to examine our organizations, and we need leaders, leaders taking charge and saying, as a school, like Colorado School of Public Health, our Dean John Salmon has stated, we are going to dismantle structural racism. And this is our plan. And this is what we're going to put into position. We need leaders. But then, Jen, it's all of us are leaders. So I don't want you to say, you waiting for the leader, because that leader could be you that needs to rise up and be a voice for change. But really thinking leaders looking within their own organizations, conducting equity assessments, ensuring that, how do they need, looking at their policies, practice, and procedures through an equity lens to ensure that they're not perpetuating inequities. When I think about, well, what can we do at our local communities really to see the change? We want to make sure that we're providing accessible reproductive health care that is responsive, then this is the key, that is culturally responsive to the needs of Black women. And so, that's real talk. We can't have a one shoe size fits all approach to working within any communities. There's a uniqueness. And even when we clump the Black community, we have Black immigrant populations, we have African American, different regions, different locations. So knowing the uniqueness to your community to be responsive. And I like some of those preconception health efforts. There were some times where preconception, really thinking of women's health before they get pregnant. There was work with historically Black colleges and universities to have preconception health work. We need to see that across all colleges and all and even within our school age children. And so it's advocates ensuring women have access to quality care before, during, and after pregnancy. I think that that's what's key. And then on that policy level, and we see this going, expand and protect access to trusted community providers. So, we want to make sure that we're reaching out to community providers to who people trust. So that is things like the Colorado Black Health Collaborative, making sure that they receive the funding, they are in the community, they have the trust. But then on a policy level, and this is where I was going, partnering with communities, and there's key things, all of us coming together on a multi-systemic level, and then push for policy to expand paid family and medical leave. These are things that we're seeing at a local level, but leave so folks can take care of their kids, and to have that time, alleviate some of these stresses and burdens off of women. I mean, even with COVID-19, we're hearing a lot of women had, because of remote learning, high rates of Black women have had to leave the workforce, to take care of their kids. And then we also want to expand protections for pregnant workers. Mm-hmm. So how, and like I said, we're really thinking that preventative aspect in ensuring, but making sure that, so I think that that's key, expand protection for pregnant workers, but really provide accessible reproductive health that is culturally responsive, and really establishing that trusted network, and creating networks in community, I think are key in building this type of work.
Yeah. Well, I'm looking at our time and we're almost done. So I have one more question for you. And
okay,
what would you say to students looking to come into equity work, into Black women's health or infant mortality? How would you advise them kind of starting out with their equity lens within public health?
First of all, I think it's great. One of the things is never, our data tells us a story about, tries to tell us a story about community. You'll look at these data sets, and what I hope with students is that they would look into the why of the data. And when we look at the why in the data, it really points to inequities. And so one thing that as students going into the community, you must never forget or minimize the strength and the resiliency of the Black community. So you don't go in there, woe is me, and I'm going to come in and save you all from yourselves, because that's the mentality that has perpetuated the inequities, is really knowing that there's a resilience within the community, there's a strength, and really listening to the needs of community. Make sure that, because sometimes we get our educational backgrounds and attainment and think we know it all, but the point is there's a lot that we can learn from community and listening to community. And then as we're learning and listening from community, make sure we're compensating community for those efforts as well too. So really ensuring that if we're about equity, we're allocating resources to support the needs of the community. So we're just not going out on the community and I'm the only person getting paid and the community members are volunteering their time. We're compensating. We're ensuring you're recruiting on your teams as future, scholars and leaders in public health, because you all are emerging leaders in public health, ensuring that you recruit and retain Black workforce, ensuring you have diversity of your teams. I mean, those are things that you should be thinking right now is, how am I promoting equity? Am I listening to the voices of Black communities in those different areas? And just note that Blacks have persevered when faced with continued adversity and injustice. And I just know that we are resilient. That's my community. I'm a part of that. And we just want you all, as you're going into community, really go in with knowing that there's a lot of strength, resiliency, and then be a part of change. Really promote the advancement of equity, ensuring that you've checked your own biases before you've gone out into community, your own preconceived, you've done your internal work to really come in as a practitioner, leader in the community through that equity lens. Because if you haven't done your own internal work yet, and only have I examined, do I know my biases? Do I need to take some implicit association tests? Do I know my blind spots? That will make you a strong scholar, a strong practitioner in our communities and support engagement. And it's a journey. You never arrive. So if you do it once in a class, you'll be ready to do it another year and you're continually growing and educating yourself. Just like I said, Jen, I'm not done yet. This part of Cerise, there's still much to learn. None of us have arrived on this equity journey, and we have to continue to learn, walk in cultural humility, and really thinking and checking yourself. Self-reflection is one of the best things to do. Reflect on your practice. Am I treating people fairness? What am I doing to promote justice? Is equity and fairness and justice one of my core values? And how do my values translate into my actual practice? So you can have the theory, but do you really walk it out in practice?
Gosh, I could listen to you talk forever. Your experience, your lens on the world, just your passion is absolutely amazing. And I can't thank you enough for taking the time to share it with us and just spread your knowledge. So I really appreciate your time, and I wish we could delve more, but I'll have resources available for everyone touching more on this topic. And of course, with this video, you can always look up Cerise Hunt on our Colorado School of Public Health page. She does amazing things. So thank you so much.
Thank you, Jen, for the invite, and may you all have a good semester. Thank you.